You step out of the ambulance. It's 2 in the morning, freezing rain is coming down in sheets, and a sedan is wrapped around a concrete pillar.
Yeah, a total nightmare scenario.
Right. And someone inside is screaming. There's this distinct smell of gasoline in the air,
Yeah.
broken glass everywhere, and you have like exactly 10 seconds to make a decision that will dictate who lives and who dies.
The pressure in that moment is, it's almost impossible to quantify because you are entirely stripped of the brightly lit, sterile, highly controlled environment of a hospital.
There's no x-ray machine.
Exactly.
There's no team of specialists standing by. I mean, it is the absolute definition of working in the muddy waters of human unpredictability. And, well, that is exactly what we're wading into today. Welcome to this deep dive.
Glad to be here.
Today, we are taking you inside the high-stakes, rapid-fire mental framework that first responders use to process total chaos. We've pulled our sources from Chapter 10 of a foundational EMT training manual, specifically focusing on patient assessment.
Right, the absolute core of the job.
Yeah, and our mission for you today is to demystify this incredibly intense process. We want to extract that structured critical thinking so you can apply a similar situational awareness to the unpredictable moments in your own life. So, okay, let's unpack this, because emergency medicine isn't just about sirens and bandages.
Not at all.
It's actually one of the most disciplined systems of information gathering on the planet.
It really is. It relies on a very logical framework.
Yeah.
But what makes an EMT exceptional is their ability to flex that framework. I mean, the textbook lays out a sequence, right? Scene size up, primary assessment, history taking, secondary assessment, and reassessment.
Pretty straightforward on paper.
Right. But out in the field, that order has to adapt continuously to the environment and the patient. You might be jumping back and forth between those phases based on a sudden change in the patient's breathing or a new hazard appearing on the scene.
Let's start with that hazard aspect, because before an EMT can even think about touching a patient, they have to navigate the environment. This is the scene size up. The manual talks about continuous situational awareness, and it emphasizes that this starts before you even shift the ambulance into park.
Yeah, you are gathering data from the moment dispatch calls you. Once you arrive, you have to consider the physical terrain before you commit.
Right.
Like, are you stepping into a slick of motor oil? Is there black ice? Because if you have to carry a 100-pound stretcher, a massive bag of gear, and a 200-pound patient back across that surface, well, a compromised footing going in is going to become a catastrophic failure coming out.
I was actually thinking about how to visualize this, and it's a lot like pausing at the threshold of a chaotic surprise party. But instead of scanning for where the cake is, you're scanning for live wires or aggressive bystanders or toxic fumes.
That's a great way to look at it.
But I have to ask you about the psychology of this. If your whole calling is to help people in distress, how do you suppress that primal human instinct to rush in and help a screaming person?
Oh, it requires an immense amount of psychological restraint. I mean, it goes entirely against human empathy. But if we connect this to the bigger picture, an EMT who rushes into an unsafe scene and gets electrocuted or, say, overcome by carbon monoxide.
They've just become a second patient.
Precisely. You have just doubled the burden on the emergency system.
Well,
You've drained resources instead of providing them. So the golden rule in emergency medicine is that any actions taken to protect the EMT should also be applied to the patient, but the EMT always comes first.
That makes sense.
You have to put on your standard precautions, your PPE like gloves, masks, eye protection. You might have to wait for the fire department to secure power lines or police to secure a violent scene. You just cannot save a life if you lose your own in the process.
Okay, so once you know you aren't going to get injured, you have to figure out what kind of puzzle you are solving. The manual breaks this down into two categories, MOI and NOI.
Right. So MOI stands for Mechanism of Injury. This is your trauma category. You are evaluating the physical forces applied to the human body.
Like a car crash.
Exactly. Was it a blunt force trauma, like a steering wheel to the chest where the skin isn't broken but internal organs might be ruptured? Or was it a penetrating trauma, like a gunshot wound, which carries very different immediate life threats?
And then NOI is nature of illness, which is for medical emergencies.
Yeah, and the NOI is usually guided by the chief complaint, what the patient tells you is wrong. But you're also looking for environmental clues.
Like what?
Like spilled medication bottles on a nightstand, or a hissing home oxygen tank, or even a strange sweet smell in the air. Those could point you toward a diabetic emergency or toxic exposure.
Right.
And simultaneously, you are counting the total number of patients to determine if you need to call for backup, initiate the incident command system, or begin triage.
Sorting out who needs help the fastest. So the scene is safe. You know generally what you're dealing with. Now the transition happens. The focus narrows entirely onto the patient, which brings us to the primary assessment.
Yes. The singular defining goal of the primary assessment is to identify and treat immediate, imminent life threats.
So no deep diagnostics yet.
None. You are not taking blood pressure yet. You are not asking about their medical history. You are looking at the patient and forming a rapid general impression.
The text mentions noting their age, sex, distress level, and positioning. I found the positioning part fascinating. You can, look at how someone is sitting and immediately know how close they are to dying.
You absolutely can. For instance, if you walk in and see a patient sitting on the edge of a bed, leaning forward on outstretched arms with their head and chin thrust forward.
That's the tripod position, right?
Yes, exactly. That is the tripod position. And in infants and young children, you might see the sniffing position, where they sit upright with their head jutting forward as if they are trying to sniff a flower.
What is physiologically happening there? Why those specific postures?
Their bodies are instinctively trying to align the airway structures to maximize airflow. They are literally recruiting accessory muscles in their neck and chest to force air into failing lungs.
Wow.
It requires massive conscious effort. When you see those postures, you know immediately, without touching the patient, that they are in severe respiratory distress and their body is working exhausting overtime just to stay alive.
Okay, so you visually process that, and then you have to figure out their level of consciousness. The manual uses the AVPU scale: awake, verbal, pain, unresponsive. If they're awake, you check their orientation, person, place, time, and event.
And those aren't just polite conversation starters either. They test different layers of cognitive function and memory storage.
How so?
Well, knowing their name tests long-term memory. Knowing the month or year tests intermediate memory. Knowing what just happened to them tests short-term memory. If they can answer all four, we say they are alert and oriented ×4, meaning the brain is perfusing well with oxygen and blood.
Okay, I have to stop you, though, on the piece in the AVPU scale. Responsive to pain.
Right.
The text mentions intentionally inflicting pain on a patient who is barely conscious.
Yeah.
How do you do that without just being cruel? I mean, it sounds kind of barbaric.
It can definitely look jarring to a bystander, but it is a highly specific clinical method to check baseline brainstem function. You aren't trying to cause suffering.
Right, it's diagnostic.
Exactly. You are trying to see if the central nervous system is still capable of receiving a noxious stimulus, sending it up the spinal cord to the brain, processing it, and sending a signal back down to withdraw from it.
So how is it actually done in the field? What does it look like?
You might firmly pinch the trapezius muscle on the shoulder, or apply pressure to the bone of the orbital rim above the eye, never the eye itself, obviously.
Oh, gosh, of course.
Another common method is sternal pressure, rubbing your knuckles hard on their breastbone. If the patient groans or reaches up to push your hand away, their brain is still processing signals.
If they don't.
If their body remains completely flaccid, that tells you the brain is essentially offline, which elevates this to a critical emergency.
It's diagnostic, not punitive. You're checking to see if the wiring is still connected. So once consciousness is established, we get into the famous ABCs: airway, breathing, circulation.
Right, the absolute basics. You ensure the airway is physically open. You observe if they are breathing adequately, which means not just gasping, but actually moving enough tidal volume in and out of the lungs. And for circulation, you check the pulse and evaluate the skin color and temperature.
But there is a massive exception to this rule, right?
Yep.
The ABCs are not absolute.
They are not. If you walk up to a trauma patient and there is a life-threatening arterial bleed, squirts of bright red blood, you throw the ABCs out the window. It instantly becomes CAB, circulation first.
Because you have to stop the leak.
Exactly. You must apply a tourniquet or massive direct pressure immediately. Securing a pristine airway and pumping oxygen into the lungs is completely useless if all the red blood cells needed to carry that oxygen to the brain are actively pooling on the pavement.
Yeah, that makes terrifying sense.
You plug the hole first.
And once you've stopped the massive bleeding and checked the airway, the EMT does a rapid 90-second physical sweep of the body. The manual calls this DCP BTLS, which honestly sounds like a weird electronic music duo.
It really is a massive acronym. It stands for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling.
Does anyone actually remember all those words in the middle of a car wreck?
The acronym itself becomes muscle memory, but what they are really doing is hunting for hidden trauma. Like in winter, for example, a patient might be wearing a thick parka.
Oh, right.
You might not see a puncture wound to the chest, but if you run your gloved hands firmly down their torso and feel a crunching sensation, which is called crepitus, or feel a wet spot, you've just found a life threat that the eyes missed.
And all of this rapid assessment culminates in a critical decision, transport priority. Like, does this person need to leave right now in an ambulance with lights and sirens, or can we stay on scene a bit longer? And this ties into a concept called the golden hour. The text mentions it, but I want to dig into the why. What makes those 60 minutes so magical?
Well, it's less about magic and more about cellular biology. The golden hour, or golden period, is the critical window from the moment of severe trauma to the moment the patient reaches definitive care, which usually means a surgical operating room.
What happens physiologically at minute 61, though? Why does the body suddenly give up?
During severe trauma, the body goes into shock, which is essentially widespread inadequate tissue perfusion. The cells aren't getting enough oxygen. So to survive, the cells switch from aerobic metabolism, which uses oxygen, to anaerobic metabolism, which doesn't.
Sorry.
The problem is anaerobic metabolism produces a massive amount of lactic acid as a byproduct.
So their blood is literally becoming acidic.
Yes. And as the blood turns acidic, it destroys the body's ability to clot. It also impairs the heart's ability to pump effectively. This leads to hypothermia, which makes the clotting even worse.
A vicious cycle.
Very much so. It's known as the lethal triad in trauma: acidosis, hypothermia, and coagulopathy. Once that cascade gains momentum, it is nearly impossible to reverse, even with all the blood transfusions in the world. So the golden hour is the race to get the patient to a surgeon before that cellular cascade reaches the point of no return.
Wow. That fundamentally changes how you view a ticking clock.
Hmm?
It's not just about getting to a hospital, it's about outrunning a cellular collapse.
Exactly.
Okay, let's say the massive hemorrhage is controlled, the airway is open, the immediate threats are managed. The patient is stabilized enough for the EMT to shift gears. They transition from a first responder into a medical detective. This is the history-taking phase. And here's where it gets really interesting. The manual strictly warns against cookbook medicine.
Cookbook medicine is dangerous. It's the practice of mindlessly following a checklist of symptoms and jumping to the most obvious conclusion without actively synthesizing the data.
Right.
Emergency medicine requires a continuous critical thinking loop. Gather, evaluate, synthesize.
Give me a real-world scenario of how cookbook medicine gets somebody killed.
Let's say you get called to a subway station at 1:40 a.m. A patient is stumbling around, highly aggressive, slurring their words, and smells like alcohol. Cookbook medicine says, oh, this person is intoxicated, they are just a public nuisance. You toss them in the back of the ambulance and ignore them.
But a detective EMT looks closer.
What's fascinating here is that a critical thinker evaluates deeper. They know that aggression and altered mental status are primary symptoms of hypoxia, the brain starving for oxygen.
Oh, wow.
Or it could be extreme hypoglycemia, dangerously low blood sugar, or perhaps they have a traumatic brain injury from a fall they don't even remember. By blindly following the intoxicated recipe, you miss the fact that the patient's brain is dying.
To avoid that trap, they use structured mnemonics to gather the story. They investigate the chief complaint using OPQRST and gather a background using sample. We won't list every single letter because it's overwhelming, but I want to focus on why these specific questions are asked.
Sure.
In the sample history, for instance, you ask for the last oral intake. Why does it matter if a guy with a broken leg had a cheeseburger an hour ago?
Because if that broken leg requires emergency surgery, the anesthesiologist at the hospital needs to know exactly what is in that patient's stomach.
Oh, because of choking?
Exactly. When you paralyze a patient to intubate them for surgery, their gag reflex disappears. If they have a full stomach, they can vomit and aspirate that food into their lungs, which is often fatal. The EMT gathering that simple detail in the field dictates how the trauma team manages the airway hours later.
So every question is a setup for the next phase of care. What about OPQRST? The P stands for provocation or palliation. What does that actually tell you?
It asks what makes the symptom worse and what makes it better. If a patient has chest pain and the pain gets worse when you push on their ribs, or worse when they take a deep breath, it might be a musculoskeletal issue.
Like a bruised rib.
Right. But if the pain is constant, crushing, and nothing makes it better or worse, that points heavily toward a cardiac event.
And while you are gathering all these clues, the text emphasizes listening for pertinent negatives. This concept is fascinating. It's like finding the invisible man by looking at the footprints in the snow.
It is the clinical art of documenting what the patient is not experiencing. If a patient complains of a severe sudden headache, you would expect them to also have blurred vision, nausea, or numbness in their extremities, classic signs of a stroke.
Right.
If you ask and they explicitly deny having blurred vision or numbness, those are pertinent negatives.
Mhm.
Documenting the absence of those expected symptoms is just as valuable to a neurologist as the positive symptoms. It narrows the diagnostic field.
So you've gathered this story from the patient, you've looked at the negative space, but I mean, people aren't always reliable narrators. Sometimes they lie, sometimes they are confused. How do you physically fact-check the story they've just told you?
You move into the secondary assessment. This is a deep, systematic physical exam. You use inspection, which is looking carefully. You use palpation, which is feeling for abnormalities. And you use auscultation, which is listening with a stethoscope.
You're checking if the pupils react equally to light. You're looking for jugular vein distension in the neck, which can indicate heart failure. You press on the pelvis to make sure it hasn't shattered, and you listen to the breath sounds. The manual specifically mentions listening for something called stridor.
Yes, stridor is one of the most alarming sounds you can hear in the field. It is a harsh, high-pitched, brassy crowing sound that happens when the patient breathes in.
It sounds terrifying just describing it.
It is. It indicates a severe narrowing or partial obstruction of the upper airway, often from swelling due to an allergic reaction or an infection or a foreign body stuck in the throat. When you hear stridor, the airway is closing rapidly.
This is also the phase where you finally get precise vital signs. You aren't just guessing if they're breathing fast. You count the respiratory rate. You check the pulse. But the manual notes you have to change where you feel for a pulse depending on the patient.
Yeah, for adults and older children, you typically check the radial pulse at the wrist. But if you have an infant under 1 year old, their necks and wrists are often too chubby to reliably feel those arteries.
Right, they've got those baby rolls.
Exactly. So instead, you palpate the brachial pulse, which is located on the inside of the upper arm, between the elbow and the armpit.
You also do a deep dive on the skin to check perfusion. You are looking for cyanosis, that blue tint that means the tissues are starving for oxygen, or jaundice, a yellowing indicating liver dysfunction, and they measure capillary refill time.
This is especially crucial in pediatric patients. You squeeze the fingernail bed until it turns white, forcing the blood out of the microvasculature. Then you let go. It should return to a healthy pink in under 2 seconds.
And if it takes, like, 4 seconds,
That is a massive red flag. It means the body is actively shunting blood away from the extremities to protect the vital organs in the core. It is an early sign of shock.
and that leads perfectly into the final phase, reassessment. You have to repeat this entire process every 15 minutes for a stable patient and every 5 minutes for an unstable one.
Correct.
I mean, this is basically like running a full system diagnostic on a spaceship while it's actively re-entering the atmosphere. But I have to admit, checking vitals every 5 minutes seems exhausting. If you've already controlled the bleeding and secured the airway, why the constant repetition?
Because the human body is a master of deception. It has a profound physiological ability to compensate for severe trauma, particularly in young adults and children. Yes, their cardiovascular systems are so healthy that they can constrict their blood vessels and ramp up their heart rate to maintain a perfectly normal blood pressure, even while bleeding internally.
So a kid could look perfectly fine on the monitor while slowly bleeding to death.
Absolutely.
Yeah.
Their body is working at maximum capacity to maintain the illusion of stability. But eventually, the body runs out of energy to keep up the charade.
And then what happens?
The compensation mechanism suddenly fails, and they fall off a physiological cliff into decompensated shock. Their blood pressure crashes rapidly, and once that happens, survival rates plummet.
And that's why 5 minutes matters.
Exactly. If you are only checking vitals every 20 minutes, you will miss the warning signs leading up to the cliff. Reassessing every 5 minutes allows you to spot the subtle trend. A heart rate creeping up, a respiratory rate slightly elevating long before the blood pressure drops. Catching that trend is how you save a life.
It is incredible. So let's take a step back and look at this entire framework. We've seen how an EMT takes a terrifying, chaotic landscape and overlays a grid of absolute logic onto it.
They have to.
They secure the scene so they don't become part of the tragedy. They hunt down the immediate active life threats in the primary assessment. They avoid cookbook medicine by playing detective with the patient's history and pertinent negatives. And finally, they relentlessly fact-check their findings with a deep physical exam and constant reassessment. They replace panic with protocol.
It is a profoundly human system of reliance on the senses, looking, listening, feeling, and critically analyzing in real time.
And that brings us to the end of our deep dive today. But we want to leave you with a thought that takes this a step further. We just spent this time exploring the intensely human, boots-on-the-ground nature of patient assessment, and you might not be treating a trauma patient anytime soon. But think about your own high-stress situations.
Oh, that's an interesting angle.
Right. Next time you walk into a chaotic meeting, a family crisis, or just an overwhelming project, what if you paused at the door to do a scene size up? What are the immediate life threats to your goal? If you can separate the distracting symptoms from the true chief complaint in your daily life, how much more effective could you be? Something to chew on. Until next time, stay curious.